COPD is caused by exposure, to things that harm the lungs, whether that's high biomass fuels in some country or particularly tobacco smoke. And I do everything I can to stop people smoking and hinder tobacco companies. And I hope you'll join in that campaign. And much of the cost, and we'll come back to this a little bit later on, is to do with these attacks, exacerbations, the COPD crisis events. And we've already heard Dr. Rajan mention how the words COPD don't mean very much to patients. Well, actually, maybe the word exacerbation is not very useful either for everyone in the globe. We can talk about that. And this is the saddest thing. The saddest thing now, as was predicted 10 years ago, was that COPD is now the third leading cause of death worldwide. And this has happened actually earlier than was predicted. And so it is now front and center on the minds of the World Health Authority after ischemic heart disease, stroke, and is taking over from respiratory infection and these other global killers. So COPD is a huge issue. And this is the truth of COPD. And Mona has alluded to this in her case already. You've got to ask yourself, why do people come to see doctors? What has gone wrong? Well, COPD certainly begins with a physiological change, a loss of lung function, maybe exacerbations, maybe the COPD crisis events causing accelerated decline, which then leads to breathlessness. And when humans become breathless, or when humans have a problem, they adapt. It's one of the great strengths of humans. But by adapting to breathlessness, you avoid breathlessness, and that means you become inactive. You then decondition, and that leads to a vicious downward spiral of functional deterioration, which leads to disability and eventually mortality, early mortality. This is driven through a loss of quality of life. So the question has to be, where does this process occur? Where does it start? But also, where can we intervene? Because as I've said, and I'm going to make the case in a moment, many people have become breathless and inactive as a result of the disease significantly before they present to any healthcare practitioner to make the diagnosis. So the key question is, can we make that earlier? And this is the problem. At presentation, people are already significantly declined. It's so sad to say that Mona's case is not in any way untypical. You have this CT scan there, which has got severe emphysema. You've got gas trapping of 200% predicted with significant problems. The patient is already breathless and doesn't respond to the immediate reliever medication. And this patient has a quality of life impact already. They have to have that to come to the doctor. And I'm arguing very clearly that actually, because they present too late, we can't give them the right treatments. It's not just about drugs, and I'll unpack that for you in a moment. And therefore, we lose those benefits and we lose the patient. And as Dr. Rajan said, we often risk then permanently losing the patient because of a lack of faith maybe in us or understanding of what we're trying to do. And if you look in general at numbers, this is a study done by Professor Price, and that we published in the International Journal of COPD, of over 25,000 patients. And you can see here, if we classified by the gold lung function status of these patients, gold 1 being mild through to gold 4 being very severe, you can see only 20% approximately were in gold 1. The vast majority are in moderate to severe disease categories. And I would go back to the discussion we've just had about cardiologists. Would a cardiologist be happy if a patient had lost 50% of their heart function? The answer absolutely is no. So we in respiratory disease have to, I think, challenge that absolutely as well. So we've got to diagnose these people earlier and sooner. The pathway to diagnosis is complex. This is a graphic taken from the NICE guidance. This is our National Institute of Clinical Excellence guidance that we use as our standards in the United Kingdom. And we're challenging people now, and this is important, to look for symptoms over the age of 35. We're rejecting the idea that COPD is a disease of elderly people, because actually it is a disease clearly occurring younger. So if you ask people at a younger age, are you breathless? Have you got a chronic cough? Do you bring up sputum? Then maybe they'll say yes. And if they're a smoker, then they've got a risk factor there for the development of COPD. And then these issues of frequent winter bronchitis mustn't be ignored. Frequent respiratory, what we would consider minor illness, because these are often the flags that then raise the possibility of the diagnosis of COPD. And then obviously what things we have to look for is the risk factors, the occupation, exposure to fumes and biomass fuel, as well as obviously smoking, and test patients at the beginning to see how they are. The diagnosis is clearly based upon spirometry. And how do we classify COPD, or how do we make sure it's COPD? Mona's already mentioned that this disease, unfortunately, is irreversible. And when you talk about the difference between asthma and COPD, COPD causes breathlessness, which is generally progressive over time. And one of the key things I always ask my patients is, interestingly, when were you last well? When were you last not breathless? And they'll often think, pause, and say, maybe that was some years ago. Then I've really challenged them. Then I've asked them, when did it start? I talk about chronic cough that may be unproductive, but it be intermittent, and it may be associated with wheeze. We'll talk about sputum, because that is typical of the bronchitis side of COPD. And then obviously, as I've already mentioned, we'll talk about lower respiratory tract infections. Have these been occurring? Have these been missed? And importantly, perhaps, where were they managed? Because it's possible that rather than going to seek help from a doctor or somebody who could possibly make the diagnosis of COPD, they've sought maybe a community pharmacy or other neighborhood kind of approach, which may not lead to the diagnosis because they'll manage the infection or the attack they're having in front of them. So these things are very, very important to actually do. So what's going on? Well, this is the reality of COPD, and I'll explain why this old Fletcher-Peter graph is perhaps not as right as we thought it was. This was some work done, very classical work done, published a long time ago now by some very famous respiratory epidemiologists who looked at smokers, early non-smokers, and followed their lung function for a short period of time while they were working. And unfortunately, what this group did was they extrapolated at either end of the curve to think lines were actually straight, when in actual fact they're not, and I'll show you that in a moment. They then raised a level of disability and also a level of death based upon lung function. We know that people with even mild FEV1 deficiencies in COPD can have significant disability. So setting a line is not helpful. And we also know that people even with mild COPD as measured by lung function can die of their disease. So again, these lines aren't very helpful. But this group did very clearly show that actually if you stop smoking, things get better. And that's a very important message. And this was a fundamental way of raising the awareness of COPD. But what's really going on? Well, here's a study published by Claudio Tantucci from Italy, which showed very nicely that if you take people as, again, from the gold categories of COPD, mild, moderate, severe, very severe, based upon lung function, that it's the people with the highest levels of lung function that seem to lose the most lung function. And actually, as you get more severe, the loss of lung function actually declines. Now, we're not sure what's going on here, but this research has been replicated now in 2 or 3 other studies, both prospective and also database studies, to show the same effect. It may be a numbers game. So the people with the most will lose the most if it's a pure percentage. But actually, it seems to us really there's a particularly difference in biology that could be occurring, and I'll explain that a little further in my talk. We know these exacerbation events are absolutely critical. And it's really important to remember that even people with mild disease are at risk of exacerbations, at risk of the COPD crisis. And interestingly, this work by Mark Dransfield from America, again, clearly showed that actually with people with better lung function, if they have an exacerbation, decline faster. So this is critical. Again, this has to be a flag for us to raise, which has to be asking our patients, but also asking people who may see our patients, is anyone having these attacks? Have they got risk factors for COPD? Could they have COPD? Because we miss the boat here. We're missing the events. And we know very clearly that these events are not just about the lungs. And we've already spoken and discussed the cardiology crossover perhaps a little bit. Well, actually, in scarily, that both there are short-term and long-term effects of COPD exacerbations with increase in myocardial infarction, as well as stroke, both in the first few days and later after the event of exacerbation of COPD. So we need to be aware of this, and maybe we need to ask our cardiologists for help in actually how to risk manage patients for their cardiovascular disease as well as their respiratory disease at time of crisis especially. So I asked these questions. Can we diagnose COPD earlier? What can we do to do this? And I thought, well, we could do screening for COPD. We proposed this in the United Kingdom, and you've already discussed how spirometry is somewhat limited, but it would be potentially possible, but no one's really done it. Definitely, as I've already mentioned, we need to work together to pick up these events, to pick up where the patient touches on healthcare workers, to actually maybe think, hold on, could this patient actually have COPD? Because patients present at different times and in different places. And a recent piece of research performed in Canada beautifully showed that the numbers of contacts with healthcare rapidly increases in the 3 years before a diagnosis of COPD is made. So that maybe there were opportunities that were missed by the healthcare workers when the patient went to see the pharmacist, went to see the nurse, or maybe had some other routine work done. But this is what goes on with the late diagnosis of COPD. And then finally, can we diagnose earlier by asking the right questions? And again, we've touched on this, talking about the individualization of care, the effect on people's lives. Asking people, are they breathless? And they'll say, no, they're not breathless. Why are they not breathless? Because they're not doing any activity. They're avoiding the activity. They've adjusted their lives. So actually, if we ask the right questions, are you more breathless than your peers? Can you do the same things as you were doing a year ago or 2 years ago? Can you play with your grandchildren and do the things you want to do? And if they say no, then you ask them, why is that? Well, that may be because they're breathless. And that's maybe how we can diagnose earlier. There's great evidence on this. This is a nice piece of work done by a pulmonary physiologist called Dennis O'Donnell from Canada. And Dennis beautifully showed that even in mild disease, the impact of exercise on breathlessness is dramatic. Is this captured by spirometry? Absolutely not. So maybe, again, we need to do some other tests which are perhaps more physiologically impactful than spirometry alone. Does it make a difference? Because we have to know that if we do screen or we do ask the right questions, then actually we can make a difference. And I'm going to show you we can. One of the key things I have in my mind is activity. So can we impact with activity? Well, yes. This is a very nice piece of work from the Copenhagen city study, which looked at patients over time, looking at their survival from COPD and also their mortality rates, all cause, depending on how they exercise, whether they exercise a lot or in a very little amount. And there is a clear graduation of effect if you exercise more in COPD. Impacting to increase exercise is therefore so important, and getting people back to where they were maybe a year, 2 years, or 3 years prior to their point of diagnosis. We also know that exercise impacts on rate of change of lung function, again, from the same data set, clearly showing that people who exercise more lose less lung, in fact, no lung, compared with those people who exercise less. And indeed, to a degree, the effect of smoking is controlled by exercise itself. So this is such an important thing for our patients to be doing. As you can see here, this is all subjects with a difference in low exercise, losing lung function, 17.9 mils, high people not losing lung function, and even similar events if you're a smoker or not. So how do we manage COPD? What are these early things? I will talk about medication in a minute, but actually education, self-management, understanding of the disease is so important. Nutrition, very simply, if someone is got a low body mass index, you need to increase their body mass index. If they've got a high body mass index, you need to lower it to a degree. Smoking cessation is one of those things which is fundamental to what we can do to lower the mortality, the impacts, to improve the quality of life in people with COPD. And actually, the sad thing is the majority of our patients, by the time they have severe disease, have stopped smoking. So we've missed opportunities earlier to do this. And exercise training is fundamentally important with massive benefits from pulmonary rehabilitation. Mona mentioned how she would treat her patients. She mentioned the impacts of the disease on her patients and what you need to focus on. Patients want to feel better. Patients want to have fewer symptoms, less breathlessness. They want to be able to improve their exercise tolerance. I think we need to challenge them about that and improve their health status. But interestingly, those that have had exacerbations also do not want to have frequent exacerbations. And so we have these two goals. One is to reduce the symptoms and the other one is to reduce the risk. And I think activity is the key, because if we do give people the appropriate medication, they do increase their activity and reduce the risk of exacerbations. Mortality, well, that's something yet to be seen. And there are some hints in new studies that mortality benefits can be seen. And indeed, hints to prevent this disease progression that actually these benefits can be seen if we treat early enough. Obviously, we need to review, assess, and adjust therapies at all events, at all contexts. Mona's also mentioned what GOLD, the Global Initiative for Obstructive Lung Disease, the global strategy for obstructive lung disease tells us about treatment, how non-specific it is. And I agree with Mona. I have never cured a patient of COPD. I've never made somebody go completely asymptomatic. Or if they do think they're asymptomatic, then perhaps they're not exercising enough. But the GOLD has helped us in that it has allowed us to categorize patients by symptom severity, low symptoms and higher symptoms, and also risk of exacerbation, and has suggested new treatments for us. But again, as was illustrated in this case, short-acting therapy is just that, short-acting. It is not fundamentally going to change anything in the disease, whereas we need effective long-acting bronchodilators to open up the lungs, to improve exercise capacity, to reduce to improve quality of life, as well as medications when used together in the right patients. And that's an important point, that actually reduce the risk of exacerbation and hospitalization, which leads to mortality. But also, let's not forget, it leads to progression of lung disease. And what's so sad is that actually the treatments we use, the paradigms we use, are really a paradigm of progressive failure. And I'm going to use that and let you think about that for a moment. Would a cardiologist accept waiting for a second, a third, a fourth event to occur? Each one of those events could kill the patient. Each one of those events takes away lung function. And each one of those events then occurs more frequently and with closer frequency to actually occur more quickly. Would the cardiologist do that? Well, that's what we seem to do. And maybe we're not doing it absolutely correctly. And that's something perhaps we can discuss. And then finally, I've got this rather complicated slide here to show you. This was borrowed from Professor Gary Anderson. I'm using it with his permission today. Professor Anderson is a professor of respiratory biology from Melbourne in Australia. And he gave a fantastic talk at an international conference a couple of years ago. That really unpacked the idea that what we're seeing in clinical presentation is actually too late in the biological and scientific progress that occurred with the disease. So if you think about this being a clock with time going by, if you start at the top and move clockwise round, we can see that the impacts of cigarette smoking are to reduce antioxidants in our bodies, to increase oxygen assaults on our bodies, to change the impact, to change the ability of our white cells to respond to those attacks, which leads to epigenetic imprinting, which leads to changes in protein production, which then leads through to other changes in actually the fundamentals of the metabolism of our cellular cells. This could lead to colonization, for example, with bacteria. And we certainly see a different microbiological environment in people's lungs with COPD than we see in normal people. And this then leads to our bodies actually becoming used to the problem, but also exhausted at dealing with this. And this then leads to the damage which we're occurring. And so Professor Anderson very beautifully argued that the emphysema we're seeing, that the presentation with breathlessness that we're seeing, that the frequent exacerbations that we're seeing is the result of the exhaustion of our bodies to respond to the damage which we've been having. And we are not able early enough to pick up that damage, to detect those changes in the microbiology, in the cellular function, and in the defenses of our body against those insults, leading then to the disease which does not respond well to therapy, that is progressive, that, as Mona said, is often irreversible. So my summary, COPD often presents late, and it often is too late. And that's a scientific argument and certainly an argument clinically. We need to look for COPD early, and I think we need to look for it to prevent this disease progression, to improve this exercise capacity and quality of life, and get the patient on the right medication for them to optimize benefit and to stop this risk, this second event, third events, because again, other people would not accept that in their specialities. We also, though, need to find people early as possible to allow us to understand scientifically the processes underlying COPD. And I would argue that over the years, over the last 20 or 30 years, we have investigated those with severe disease. And I think it's arguable to say, do you know what? Those are the wrong people to be investigating because they have effectively a burnt out defense, a burnt out lung with just damage accruing and accruing and accruing without any fight left in them. So I think we can be positive. I think we need to find these people with COPD and we can impact on them. And the other message I would want to give you is we need to ask the right questions of our patients with COPD, because at the moment we don't always do that. And asking them when they were last well and when they were last less breathless or not breathless could be the key question. So thank you for listening to that.